I'm Dr. Preeya Gupta, and today we're going to be talking about ocular surface evaluation and tune-up and my top pearls as it relates to refractive cataract surgery. These are my financial disclosures. So pearl number 1, it's really important to make the diagnosis of ocular surface disease before surgery. There's a potential negative impact of dry eye disease on cataract and refractive patients. And for anyone that has experienced this in their own clinical practice, we know that patients are really unhappy when they have ocular surface disease. They can complain of poor vision quality. The proof study shows that in their patient population, despite having 20/20 vision, over half of the dry eye patients in this study complained of moderate or worse blurry vision compared to only 14% of controls. So it's telling you that testing patients' vision and just saying, hey, all 20/20s are created equal, that's not really the case in our dry eye patients. Patients can have a refractive surprise if they have dry eye disease. There's data in the literature that suggests that hyperosmolarity can lead to variability in both keratometry measurements and resulting IOL power errors. And last but certainly not least, our dry eye patients significantly have a lot of discomfort and pain after cataract surgery. These are the patients that come in and say that, surgery was horrible, I had all these complications, and when you ask them what happened, they complain of dry eye symptoms. Because a lot of us had noticed a high prevalence of patients with ocular surface disease in our cataract population, Dr. Chris Starr and I decided to do a study looking at the modern day prevalence of ocular surface disease in cataract patients. And what we found was that 80% of the patients in our study had some level, at least one abnormal test that could have been MMP9 testing, osmolarity, or corneal staining that suggested ocular surface disease. So it's actually more common that a patient in our chair presenting for cataract evaluation would have dry eye than not. Interestingly, I think it is really important for us to start screening patients because in our study, when we looked at how many patients were symptomatic and asymptomatic, about half of the patients didn't actually present with symptoms, but 85% of the asymptomatic patients actually had an abnormal point of care test. So it tells us that we really need to be screening these patients if we want to try to treat them in advance. Pearl number 2. Use point of care testing to help make the diagnosis of ocular surface disease. We know from the TFOS-DUES-2 definition of dry eye disease that indeed a lot of dry eye is centered around hyperosmolarity and inflammation. And as such, I think it's important that when we look at diagnostic tests, we want to find tests that actually address or identify hyperosmolarity and inflammation. So let's start with osmolarity. The osmolarity test is a point of care test. It's easily accessible, readily available, and characteristic of dry eye patients is that they will have variability in their reading. So if you tested a dry eye patient 5 times in a day, they'd have a wide swing in numbers, whereas someone without dry eye would have a narrow range. In my own clinical practice, when I get this test, I like to use it as a screening test. And anybody with a value of 308 milliosmoles per liter or higher, or an inter-eye difference of 8 or more, is suggestive of dry eye disease. MMP9 is also a commonly available test. It measures MMP9 levels, which is a non-specific marker of inflammation. It's been shown to be elevated in dry eye, and it has a high sensitivity and specificity. You can see from the image here that it's a test that results in a kind of qualitative information. So positive is any pink line, but the more MMP9 that's present, the darker the line. So point of care test is helpful because it makes diagnosing dry eye more efficient. It's easy to integrate into clinical practice, and it can largely be driven by the technicians who can ask patients questions so they can decide who to screen. I think it's helpful to diagnose not only dry eye, but also other forms of ocular surface disease. And I think overall it's just a more effective screening tool because, as we know, not all patients complain of symptoms. Pearl 3, use an algorithm. It can be pretty overwhelming to decide who you're going to screen, how you're going to screen them. And the ASCRS Corneal Clinical Committee, which I'm a member of, put together this algorithm to help guide cataract and in particular refractive surgeons on how to screen their patients. So we talked about how screening and evaluating and identifying disease is very important, but we also need to know how to manage that and also how to do a targeted exam looking for ocular surface disease. So first, what you'll see here is that we ask for the identification of both signs and symptoms. So patients will get a questionnaire. There's the ASCRS Speed 2 questionnaire, which combines the traditional dry eye MGD questions with questions that can help the cataract and refractive surgeon to identify patient goals. For identification of signs, patients undergo osmolarity or MMP9 testing, as those are validated tools to help screen for dry eye. If the patient has any abnormal symptoms, that is considered to be a positive screen, or if they have any abnormal signs. I think the targeted clinical exam is really one of the highlights of this algorithm. We coined the mnemonic LLPP, and this is really should take no longer than 30 seconds. We want everyone to look at the lids, look at how someone blinks, look at the meibomian glands, lift the upper lid and pull to assess for laxity. A lot of pathology can be present in the upper lid, Salzmann's nodules, anterior basement membrane dystrophy. Push is last but certainly not least, but to express a little bit of the meibum to see what quality meibum is present, because we know that MGD is highly prevalent in our patient populations. Stains and vital dyes, so fluorescein or lissamine green, those are readily available. I like to use the strip form in my own clinical practice, and that can highlight lots of corneal pathology as well as corneal staining and signs of dry eye. So once the patient's gone through the algorithm, you can see that you can classify them as visually significant or not visually significant ocular surface disease. Anyone who falls into the visually significant category is considered to be a hard stop for surgery. They really need to be treated. The OSD needs to be addressed. And what's different than some of the traditional algorithms is that indeed we want the patients to have rapid rehabilitation because ultimately they want to get to surgery. Pearl number 4. Treating OSD pre-op doesn't have to be hard. And I really do mean this one. So kind of how I lump my different categories. So there's over-the-counter treatments, there's topical prescription medications, and then there's what I call disease-modifying procedures, which are largely aimed at improving meibomian gland disease. Let's start with the anti-inflammatory agents. So cyclosporin, 0.5% or Restasis, inhibits T-cell activation and decreases inflammatory cytokines. Lifitegrast, 5%, or Xiidra, is an LFA1 antagonist which blocks the interaction between ICAM to stop inflammation. It is FDA approved to treat both the signs and symptoms of dry eye disease. And of course, last but certainly not least here on the list is topical steroids. So the way I decide how to use these medications, for anybody that has a chronic nature to dry eye, I like to start them on one of the immunomodulators. Typically, I'll start Lifitegrast because the FDA trial data shows improvement in symptoms as early as 2 weeks. I also start topical steroids, and I just do a brief course, maybe 2 to 3 weeks in a tapered dosing. This gives you that rapid effect, but also resolution of any breakdown on the corneal surface, which might interfere with testing like topography, biometry, keratometry, etc. And last but certainly not least here, MGD treatments. So these are all largely centered around relieving obstruction and stasis. There's many different options here. Lipoflow thermal pulsation has been in the market and has lots of peer-reviewed data. Newer therapies such as TearCare and Ilux are also showing to be effective for rehabilitation and improvement of MGD. And additional therapies, intense pulse light therapy and BlephX are also being used to help not only treat the gland dysfunction, but also maybe some of the mechanical and inflammatory issues that we find with MGD. So in summary, my top 4 pearls here: diagnose ocular surface disease before surgery. Use point-of-care testing to help identify ocular surface disease before surgery, and this again can largely be driven by your staff and ancillary care providers. use an algorithm for ocular surface disease so that you kind of get in the rhythm and groove of always looking at the ocular surface so that you don't miss corneal pathology or dry eye or MGD. And last but not least, we want to think of OSD treatment in this pre-surgical population to be something that rapidly rehabilitates the surface. And I think that you should think about it from an acute and chronic perspective and choose appropriate therapies based on that. Thank you so much for your attention today.